to put it as simply as possible, neuropathy is any condition which affects a nerve. Okay, you can have sensory, you can have motor function affected, and this is where the simplicity ends. Okay, it's a vast topic. There's a lot we don't understand about the mechanisms of neuropathy. There's a lot of physiological causes. We're only going to talk about a little bit of it today, obviously, because of the time restrictions. So again, many causes. It can result from genetics. For example, Marie-Charcot tooth, where you get the peroneal nerve atrophy of the peroneal muscles. Chronic diseases, the two most common chronic diseases affecting neuropathy. Anybody know? Diabetes, hypothyroidism, environmental toxins, for example, molds from water-damaged buildings. Dr. Herkel touched on metals, mercury, lead. We get these from our foods. Alcoholism, people downplay this and say, oh, well, you know, alcoholism isn't a big deal, but I'm going to get into that in a little bit. Nutritional deficiencies. People also wonder, how can we have nutritional deficiencies in the Western world? You'd be amazed if you don't already know how many of your patients are walking in with chronic gut inflammation, which means it's permeable, which means they're not absorbing food. Even if they're having a relatively decent diet or taking supplements, they're not absorbing it in a lot of cases. And also consider that people's diet creates a lot of these deficiencies. For example, a high carbohydrate diet will result in a thiamine deficiency, relatively speaking. And so that's one of the B vitamins that's related to neuropathy. Medication side effects, such as statins for cholesterol and chemotherapy drugs are big. So again, I touched on this. Diabetes and hypothyroidism are the most common chronic diseases resulting in neuropathy. Environmental toxins, alcoholism. Marie-Charcot tooth, we talked about this. So the neuropathy can affect the myelin sheath, breaking it down, or it can affect the axon. So you have your neuropraxias, right, which is the metabolic breakdown affecting that myelin sheath. The axonomesis affecting the axon itself. In our types of practice, we don't see a lot of neuromesis, right? I mean, it's not often you have somebody walk into your office that's had, you know, a complete nerve root pulled out from a trauma. You might see it on occasion, but those people don't often end up in our offices. So they have sensory and motor effects. The sensory effects are usually paresthesia. Proprioception can be lost. The sensory effects usually begin distally. That's because of how far away the distal portion of the nerve is from the cell body, which means you're going to have more trouble with axonal transport of metabolites and proteins. Motor effects. The first one is weakness, which usually starts proximally. You'll have a loss or reduction in tendon reflexes. You got to remember that the nerve contains both sensory and motor fibers, and so both will be affected. And always remember, motor effects are going to be first. Okay? They're going to happen usually long before the sensory effects. And why is that? Anybody want to guess? The motor fibers are big. They're larger. They have more energy demands. If there's something like an ischemia from a compression affecting a nerve, the first thing that's going to be happening is you're going to lose energy production in those big nerves, and they're going to start to falter. Okay, so always remember, by the time they come to you with symptoms, they've been suffering from this for a long time. Okay, wasting only occurs if it's been present for extended periods. Differential diagnosis, we're not going to be able to get into today. It's way too big a topic, but you got to figure out, is it a polyneuropathy, a radiculopathy, etc. But the differential diagnosis becomes a lot easier when you start to consider that the topographic findings are going to limit the possibilities. The sensory findings, the motor findings are going to really set a pattern that's going to help you to determine what you're looking at. Now, getting into nutritional deficiencies associated with neuropathies. Adams and Victor's Principles of Neurology is a relatively important neurology book. It's written by a couple of Harvard medical professors, and that's why I chose to put this reference, because even within those circles, it's starting to be accepted that nutritional deficiencies are a big factor. B1, 3, 6, and 12 have all been implicated. Fat-soluble vitamins A, D, and E have also been shown to lead to neuropathy. Okay, again, some people are surprised by deficiencies in the developed world. They attribute it to alcohol abuse, malabsorption, dietary fads. Think about alcohol. 91% of the Canadian population over the age of 15 drinks alcohol. 18.6% of those people are considered to exceed low-risk drinking. Okay, so you're going to have a lot of people with problems. That's 2 out of 10 people exceed low-risk drinking standards for alcohol. In the whole Canadian population, that includes babies and kids and old people, 14.4% of the entire Canadian population drinks too much. Okay, that's huge. That's staggering. When you think about, number one, alcohol is inflammatory. You're inflaming people's guts. That's going to lead to deficiencies from absorption. You're going to increase carbohydrate calories, which again is going to lead to a B1 deficiency. Alcohol is neurotoxic. A study by CAMH found Canadians drink more than 50% above the global average, and that alcohol is now the 3rd leading cause of the global burden of disease and injury. Always consider that in your patients. Some of the mechanisms identified in the literature for neuropathy, oxidative stress. So again, Dr. Herkel touched on this. Free radical activity. Why do people have increased free radical activity? 1, diet. A lot of the stuff that people eat, fried foods, high carbohydrate diets, low nutrient diets. Stress. Stress is a major cause of a lot of ailments. And guys, you have to consider the effects of stress. I'm going to talk about it a little bit more in a couple of minutes. But stress can cause, stress will cause increased sympathetic activity. Does everybody understand what that means? You increase sympathetic activity, you're increasing your norepinephrine, your epinephrine release, you're increasing anxiety, you're increasing heart rate, you're increasing metabolic rate. What does that mean? You're increasing glucose demand. What does that mean? You're using more fuel all the time. That's going to lead to a susceptibility to hypoglycemic episodes, which on its own is going to be neurotoxic and inflammatory. But you're going to start to affect neuron function. You're going to affect cortical function when you have this increased activity. That sympathetic hyperdrive is going to cause a parasympathetic inhibition. That parasympathetic inhibition is going to lead to decreased vagal output, which will then lead to an inflamed gut. You have decreased vagal output, that's going to affect hepatic function. You're not going to have healthy biotransformation. That means you're going to have toxins floating around, more inflammation. So all of these things start to tie in and need to be considered. Oxidative stress can go up also from not enough exercise or too much exercise. Overtraining will lead to increase, and we're going to talk about some of the neuroendocrine immune effects of exercise in the next module. And nitric oxide deficiency. You guys are all aware of nitric oxide, the 3 types? Yes? Anybody not aware of the 3 types of nitric oxide? Okay. There's endothelial nitric oxide, which is released by blood flow. This is one of the big problems with nitric oxide deficiency. Lack of exercise, sedentary lifestyle. You have less endothelial nitric oxide released. You have increased blood pressure. You have damage to endothelial linings. You have inflammation, healing, increased atherosclerosis, which causes more ischemia, which causes more neuropathy. Hyperhomocystinemia is listed in the literature as a cause of neuropathy. And what they say in the literature is that the mechanism is not well understood. Consider this. Homocysteine on a lab test, if you look at a normal medical test, the range is 15. Anything under 15 is acceptable to a medical doctor because above 15, it's a cardiac risk. It damages blood vessels, it damages the heart. But what's always confused me is it's been clearly shown in the literature that homocysteine is neurotoxic over 7. So why we're so concerned about the heart and we don't care about people's brains, I don't quite understand. So by the time you have hyperhomocystinemia, your brain is on fire. You're going to have major neuroinflammatory effects. and you're going to have neuropathy as well as a lot of other problems. Thyroid, hypothyroidism, again.
So what's homocysteine for those people that don't?
Oh, homocysteine. Homocysteine is a free radical. Okay, so it goes back up to the oxidative stress. It's our most damaging free radical. It's the worst evil free radical we have. Hypothyroidism, again, linked to neuropathy. Hypothyroidism is, with diabetes, one of the most common causes of neuropathy. And again, in the literature, we're not quite sure, or so it says, we're not quite sure of what the mechanism is. Consider again, thyroid hormone is linked to the production of every neurotransmitter. Without thyroid hormone, without T3, you're going to have an inability to produce neurotransmitters. You're not going to have very effective communication between your neurons. Number two, T3 has been linked, deficiency of T3 has been linked to excitotoxicity, sorry. So does everybody understand what excitotoxicity is? Nobody? Okay, great. I'm going to talk about that in a little bit when we start to talk about some of the spinal cord changes. But it's linked to excitotoxicity, medication-induced. Again, we talked about some of the statins. We talked about the chemotherapy drugs.